Hi, everyone, and welcome back to the Mind Movement Health podcast. I have a special guest on the show. Mark, welcome to the podcast.
Thank you very much for having me, Kate.
Well, I'm super excited to have you on the show today. We're going to be diving into spinal health and scoliosis. Being a sort of rehab Pilates practitioner myself, I work with a lot of clients that have a lot of different spinal injuries, pain, surgeries, and then also scoliosis. So I know my listeners are definitely going to get a lot out of today's conversation. But before we dive in, can you please introduce yourself to our listeners?
Well, sure. I have been a practicing chiropractor in Michigan, in the States for, gosh, almost 25 years now. And I have, so for the vast majority of those 25 years, I have had essentially a scoliosis dedicated practice, where we manage all aspects of the condition, not necessarily just physical treatment. And we do a lot of small group therapy. We do a lot of telemedicine management for patients who are getting physical treatment locally, but still want all of the more holistic strategies associated or to complement what they're already doing. And we've been doing that successfully, essentially since COVID sort of forced our hand. But that has been taking off actually faster than I would have guessed. But yeah, so that's my practice in a nutshell.
Hmm. Well, I think I know from experience and my clients, trying to find practitioners that work well with scoliosis and have a really good understanding is not always easy. And a few of the sort of chiros and physios that I refer off to, they're booked up for months trying to get in, like trying to get a client in to see them. It's few and far between. So I'm not sure what it's like in the States and if, getting help is really easy or if there's only a few of, like your practice that are really specialized. How is it in the States?
Well, I mean, in the States, because we have an insurance-based model of medical practice, from a conventional perspective, um, most people fall or resort to practitioners like myself because they've already been sort of, I don't want to say dismissed, but they really haven't been given many options conventionally. Especially for people whose children have curves that are of what they would classically call a milder stage. Here in the United States and still in most parts of the world, the management strategy for milder cases is to quite literally do nothing. And and then you have to literally, as a parent, wait for that curve to get bigger to where now the orthopedic surgeon here in the States would then recommend to do bracing. And then at that point, if the curve still gets bad enough, now because you've tried bracing and it failed, now you have a medical necessity to do scoliosis fusion surgery. None of those options are really awesome. And so a lot of parents in the meantime, and to be quite honest, I don't know any parent out there who has a child in this situation who wants to do nothing. I mean, every parent, I mean, the worst thing you can feel as a parent is to feel helpless. Watching your child's back get worse or watching their posture deteriorate, that kind of thing, knowing that, well, we're just waiting for it to get worse. And the reason they're given is, well, maybe it won't get worse. You know what I mean? But the problem is the analogy I always use for that is, well, you know what? My house probably won't burn down, but guess what? I have insurance in case it does. So why not, and why not apply the old principle of, an ounce of prevention is worth a pound of cure, kind of a principle. So um, here in the States, people end up coming to me or practitioners like me when they've already been told, okay, well, we're not going to do anything, and the parents don't want to settle for doing nothing, logically, or they're in a situation now where maybe that the only option that they've been given is to wear a hard brace for 23 hours a day, and maybe the child is already resistant to doing that or not compliant with doing that, and the parents are looking for other options, either in concert or instead of. Or parents who now they're already in a situation where the surgeon has already told them, look, your child's already in a surgery threshold, or they're very, very close to surgery threshold. So now we're just going to wait and schedule your surgery date. And in many cases, that's the first time the parents even found out they had a curve, is the child's almost near a surgery threshold. And so the parents, of course, are sort of grasping at straws, trying to do anything they can to prevent surgery. And so then, of course, they do all kinds of internet research and find a practitioner like me who is a little bit more proactive, a little bit more comprehensive.
Mm. Well, 100%. Yeah, as you said, I can't imagine being a parent and then being told there's really nothing you can do, just wait for something to get worse. Like it
Right.
seems crazy.
Right. Exactly. Exactly.
So, when it comes to things like chiropractic care, how can that help people with scoliosis?
Sure. Well, I think one of the things I think it's an important distinction to bring up is that it sort of depends on your definition of the term chiropractic care. And I say that because, if I were to, go out into the general public and survey 1,000 people and say, what is chiropractic care? Probably close to 100% of them are going to say getting my back cracked or, something similar, getting adjusted, whatever you want to call it. But to me, chiropractic care, no different than medical care, means whatever I do as a chiropractor. Anything that I do or anything that I'm allowed to do that I offer to a patient I would consider chiropractic care. And so the kind of care I provide might be vastly different from the chiropractor down the street or in the next town over or in the next state over, because they might predominantly only be doing manipulation. In my practice, especially among my scoliosis patients, manipulation is very heavily de-emphasized. And in fact, most children I don't do manipulation on, and only in infrequent situations do I do it on adults, because that's not going to be the therapy that typically helps improve the situation. Now, sometimes you can help it if somebody's having a particular pain cycle that they need to get out of or what have you. And so you're kind of using it as a short-term band-aid while you're addressing the underlying reasons as to why that pain is there. But manipulation by itself rarely solves anything. And especially within the world of scoliosis treatment, it really is only a very small kind of an ancillary procedure that we do as but one small part of an entire, you know, um, conglomeration of therapies.
Mm. And what type of other therapies are you sort of using? Like when it comes to things like movement and nutrition and nervous system regulation, how important are these other areas when it comes to helping as well?
Yeah, great. Actually, yes, great. So within that confine, then, so I think in scoliosis, really we talk about it in terms of goal. So I think chief goal number one is active stability, or practitioners will often call it dynamic stability, meaning I need to teach that person's body how to hold their spine straighter in during every daily task that they do, in every posture that they assume during the day, in everything they do. I need to give them a different set point. And I need to retrain their brain as to what a different normal postural muscle memory is supposed to look like. Because in terms of our automatic postural control, right? It's kind of like as we're sitting here discussing this, we're sitting in our natural resting posture. Whether that's good or bad, it's what our brain is used to. It's what our brain's internal map says is my automatic normal sitting posture, right? But at any moment in time, I could all of a sudden sit up nice and tall, get into a nice military posture, be very upright and out. But yet, as soon as my conscious attention goes to something else, I go right back to my default setting. Again, not whether that's good or bad, it's just what my brain is used to being normal. So if I want to change that automated setting, if you will, I have to incorporate different neurological activities and exercises that reinforce the automated version of normal, not just the manual override. Does that make sense? Because obviously, when I sit up straight, I'm only sitting up straight consciously or standing straight or doing those things throughout the day for fragments of the day, moments of the day. Whereas I'm in my autopilot setting or my default setting for 99 point something percent of the day. So I try to incorporate movement strategies and dual tasking neurology activities, things that help kind of engage that autopilot setting in a different manner in ways that just also so happen to combat their curve pattern from a physical treatment sense. But then in addition to the physical treatments, we add a lot of other complementary things. So for example, scoliosis, it's well known at this point that most kids who have scoliosis have different genetic predispositions that either triggered it or allowed it to progress over time. They have bone density issues that are more pronounced than kids who don't have scoliosis. They tend to have far more hormone issues than kids who don't have scoliosis. And it's a lot of these underlying metabolic or genetic kinds of things that initially, if those are there and you don't address them, and those are the things that initially triggered that curve to happen, if I ignore the cause of this curve, no treatment of the curve, no matter what I do, no matter how comprehensive I am, is going to permanently improve that curve because I never got rid of the reason as to why that curve exists in the first place. And those things, unfortunately, don't just magically go away because that child became an adult. So now maybe that adult has bone density issues, but maybe it wasn't to a degree of osteopenia or osteoporosis. But now all of a sudden, fast forward, and now they're getting ready to go into perimenopause. And now all of a sudden, it's far easier for them to go into osteoporosis because, again, all of those factors are still there and never got dealt with the entire lifespan. And so now, if you want to help their curve as an adult, not only do you have to help their curve, but you have to kind of reverse engineer the problem a little bit and work on the bone density issues and try to do the things to help stabilize their bone density, if not try to reverse some of their bone density loss in an effort to help further stabilize the curve.
Mm.
And so those are all the factors that we look at in addition to that active stability component.
Yeah. Well, that's what I see in my practice. I've worked with a number of teenagers. I've worked with teenagers that have had their brace on. I've worked with women in perimenopause and menopause. And many of them are obviously more women than men. As far as I know from the research, tend to have scoliosis. And that's what I found in my practice. And they're often quite hypermobile too. So their joint range, as you said, their muscle tone, even their skin, is quite what's the best term for it? Not loose, but
Elastic.
very soft. Yes, like it just doesn't have that muscle tone, and they don't gain muscle as easily as some other people. So we focus a lot on stability, a lot on keeping that strength and steering clear of really end range stretching and release. Even though they actually sometimes really like it, it's not something that we focus on because they need a lot more of that strength and stability work. But they don't always really enjoy it though, because it's not super easy for them to do.
Sure.
So,
Agreed. Yeah,
so
no, we run into the same thing because again, obviously across the lifespan, and I'm sure you notice this in your practice, is that the inherent curve flexibility of scoliosis patients evolves and changes over time. And obviously the older they get, the more rigid their curve becomes. So the more flexibility training they need, especially at the beginning, to kind of help with curve flexibility. So if it is like, for example, from my perspective, if I am going to do manipulation on somebody, it's usually on somebody who's an adult whose curve is a bit more rigid because I need to generate some flexibility so that they can take advantage of all of the active care exercises.
mm. And for someone that does have scoliosis, how do they know when it is getting to the time that they need, a stronger intervention? Maybe the things that they're doing isn't working, or maybe they've had an increase in pain and they've gone back to see their specialist and their curve has increased. When do they know, it's like, oh, okay, maybe I do need to look at getting a specific chiropractor, or even beyond that, I do need to look at potential surgeries?
Well, I'll kind of go back through and answer them in reverse. So if you have somebody who maybe they're talking about surgery, I think the biggest thing, and as a chiropractor, I think the biggest misconception is that chiropractors are against surgery. And I'm not against surgery, but what I am against is just doing surgery for no reason other than cosmetic. If all of a sudden a scoliosis curve in a patient is causing them a heart or a lung impact, which is typically what it would cause from a health perspective, then obviously at that point you have to bite the bullet and have the surgery. But that doesn't happen in the vast majority of cases who reach surgery threshold. In fact, there was an editorial published in an orthopedic journal over in Asia back in 2019, I believe it was, where they were actually suggesting to raise the current surgery threshold from 50 degrees to 80 degrees because it wasn't until a curve reached 80 degrees that risk of causing a heart or a lung problem now started to occur more significantly. And that's not to say that it can't cause a heart or a lung impact at 50 degrees. But like, for example, in my practice, what I tell my patients is, look, I would like you to have the surgery if we have an objective health consequence due to the curve directly. What we can do then is we can send them for pulmonary function testing, or I can send them for a Holter monitor for, cardiac testing to see if they are having tangible impacts from their curve. And if they are, well, at least now we've established a medical reason to have the surgery, not just because it's some arbitrary number.
Makes
And so
sense.
that's how I approach surgery level cases. Now, short of that, I think going all the way back to the beginning, a lot of people, and early on when I started doing a lot of this and promoting, a lot of people sort of poo-pooed the idea like, well, how can vitamins or supplements or these kinds of things fix my curve? Well, it's not really about fixing a curve per se, but what's very interesting is just now, almost 3 years ago, there was a study done out of Romania where 3 orthopedic surgeons published a paper on children who were newly diagnosed with scoliosis. And all of their curves were basically like between 10 and 20 degrees. So newly discovered, right? So they took this whole group of kids, split the kids into two groups. And in one group, they continued to do nothing, which is every parent's worst nightmare. And then in the other group, they literally just put them on 3 specific nutrients. They put them on 2,000 units of vitamin D3 per day, 600 milligrams of calcium per day, and 1.5 milligrams of melatonin per day. And guess what? The kids who took the nutrients, their curves didn't worsen nearly as much or as often as the kids who just did nothing. So at the very, very least, if I'm a parent and I have a child who's newly diagnosed, why not at least take those things? Because those are the most innocuous things that you can take practically, especially at those doses. So why isn't everybody doing that? Because they're not going to hurt you. And if it has a real chance of keeping your curve stable, especially when it's only in the teens, well, that's going to set you up much better for the long term than waiting until the curve gets bad and now you're trying to do something about it.
And I'm assuming the D3 and the calcium is obviously for the bone strength. The melatonin
Sure.
is to allow them to get into that deep sleep, that restorative sleep. When it comes to scoliosis and knowing why a curve forms, do we know the research behind that and why some people are more susceptible than others?
Well, what's funny is after all these years, of course, we still call it idiopathic scoliosis, meaning there's no agreed upon cause. But a lot of people mistake the term idiopathic for unknown, and that's classically what it started out as, but it's really evolved into not agreed on. Because in the literature, you can find all kinds of problems that are associated with scoliosis or that people with scoliosis have that people who don't have scoliosis don't have. The hormone differences, the bone density differences, the digestive symptom differences, the genetic predisposition profile of somebody who has and who doesn't have scoliosis. So we know all of these things exist. In fact, you can go all the way back into the mid-1980s and see that there are problems in scoliosis associated with serotonin and melatonin problems. And of course, like you mentioned, melatonin is important for getting into that deeper restorative REM sleep. However, in adolescence, it's also one of the main hormones that helps signal for symmetrical bone lengthening, including vertebral lengthening. Well, if that doesn't happen right, well, now all of a sudden we get sort of this asymmetric growth, which is why it now makes it easier to grow into a curve. So all of these things are hugely important. And if you're not addressing them, and even though everybody still calls it idiopathic, we all know these things exist. It's just the problem is, at least here in the States, because scoliosis management is conventionally overseen by an orthopedic surgeon or a pediatric orthopedic surgeon more specifically, if you start to ask that surgeon about melatonin or progesterone or all of these things, they're not going to have any answers for you because that's not what they do. Pediatric orthopedic surgeon is there to say, look, do you need a brace or do you need surgery? Anything else, I'm not your person. You need to go talk to somebody else. Well, the problem is scoliosis has so many facets to it that it takes, in my opinion, far more than just an orthopedic surgeon to be involved in the management if you want to manage it properly and comprehensively.
100%. And then when it comes to sort of daily lifestyle practices that people can be doing, for scoliosis, but also just for their spinal health in general, what are sort of some of the things that you suggest? Maybe, so we've probably just talked about supplements, but nutrition wise or movement wise, what are some of the things that can help?
Sure. I think Well, I think everything starts by, garbage in, garbage out. So everything starts by what you're taking into your body. Air, clean water, clean food, food that actually passes as food, not the quasi-processed garbage that many of us eat nowadays. And I don't think it's a coincidence, by the way, that they are showing that by the year 2030, they will have a near doubling in the rate of incidence of scoliosis cases worldwide. The rates are increasing, and in fact, it's going to go from about 2 to 3% to about 7 to 9% of the population by 2030. Well, what are the commonalities among those? The quality of the food we're eating and the relative lack of physical activity that our kids are having. I mean, because they're all in front of a computer screen and they're all playing video games, they're all on their phone. Children aren't out climbing a tree anymore, or playing in the yard, or playing baseball with their friends, or whatever sports they do. They're inside being sedentary, and so of course postural activity, anything that you can do to gauge a lot of your global posture, is going to help promote a lot of neurological memory patterns that help carry you through lifelong. And even going all the way back to childhood, from a scoliosis developmental perspective, I think we have to get back to allowing kids to crawl for a long time, and reinforcing cross crawl patterns, and really getting honed in on developing our primitive reflexes, and things that we know in many scoliosis patients are off or not symmetric. And from a general posture sense, I think it's about making sure we're just moving. I mean, people don't understand, when you look at any joint cartilage under a microscope, within 2 hours of immobilizing that joint, like let's say I put my leg in a cast because I broke my knee or something, within 2 hours of immobility, that cartilage starts to deteriorate due to lack of motion. Motion is life, basically. And from a developmental perspective, if you're not moving, your brain doesn't have any real-time feedback on what to do as far as output goes. I mean, quite literally, there was an MD named Roger Sperry back in I think it was 85, who won a Nobel Prize because he was the first doctor to show that your spinal motion in particular, and all the muscles around your spine, spinal motion drives brain activity and electrical activity in the brain. And the less you move, the worse your brain works. And because your brain doesn't have the information to make any good decisions. So it just makes the best with what it has. And if that's not good, well, the output's not going to be good. And that's where we start to see a lot of problems, not just even in scoliosis, but just posture in general.
Yeah, well, I know I've had a few clients over the years that have been truck drivers, and they've ended up needing hip replacements or knee replacements because they're sitting in one position for a long period of time every day, often 6 days a week. Add that up over many years. And like you said, the cartilage just disintegrates essentially.
Absolutely. Absolutely.
Yeah. And then, if you think of the average desk worker, a lot of jobs nowadays, people are sitting for at least 8 hours a day, not doing much. So that doesn't bode well for their sort of spinal health or their brain health if they're not moving around and doing things. And we say to people, I say to my clients all the time, every 20 minutes, get up and move around, walk to the water cooler, do those things. But at the
Right.
end of the day, you really need to be moving, and we need to be encouraging more movement more frequently throughout the day. And I think if some, office places and stuff can get on board with, now we've got, the little sort of walking machines you can put under your desk. We've got sit to stand desks. At least some of these things can help people.
Absolutely, absolutely. And it's not even like it has to be a big volume of movement, or a long duration of movement. The biggest thing I try to tell my patients is, look, just do a little, a lot, or do a little regularly. Even in terms of, you know, I always use the analogy in my office, even with my scoliosis kids that I see. I tell them, look, when we talk about your exercising at home, do a little, a lot. Why? Because people are good about doing a little, a lot. Think of it this way. People are overall pretty good about brushing their teeth every day. And the reason why is because it only takes them a couple of minutes a day to do it. If all of a sudden the American Dental Association came out and said, all right, the best way to have the best oral health and to prevent cavities is to not brush your teeth every day for a few minutes, but to brush your teeth 3 times a week for 25 minutes. Guess what? Nobody would brush their teeth and everybody would have false teeth again by the time they're 30 years old. Why? Because nobody's going to set aside that kind of a time interval to brush their teeth. But most people will do a couple of minutes at a time. And of course, it's easy because, of course, every time you smile, people are going to see, hey, did he brush his teeth or not? And you can't see, you're not wearing your spine on the outside, but it still wears out the same way that your teeth do if you don't pay attention to it.
Mm.
And from a sitting and standing perspective, like you mentioned with all the ergonomics things, people don't appreciate the fact that when I go from a standing position to a sitting position, I immediately compress my spine by about an additional 25%. So imagine that extra loading. So for every 100 pounds of body weight, I'm increasing the leverage on my back by an additional 25 pounds. And of course, a great many people in the United States are 200 pounds or more. And so that's a lot of extra leverage on your back to now be sitting there 3, 4, 5, 6, 8 hours a day or longer. And of course, eventually your back is going to wear out because of that. Your back is not going to have the endurance to continually support that, especially when you're not exercising your back. And you're going to have a lot of these problems. And at some point with all of us, gravity wins. And if you don't have the endurance to fight gravity, at whatever point your back muscles fatigue out, you're going to have postural collapse. And now you're going to have the hunch. Like I have a lot of adult women, especially, will come in and say, I just want to not look like my mom. She has this big hump at the top of her back, and I don't want to look like my mom. I want to fix that. And they don't understand that a lot of that's just chronic loading over time because they're not active enough.
Yeah. And I also find with a lot of my clients, especially as they start to get older, just the simple thing from sitting to standing, they don't realize how much they're relying on their arms and their hands to get down and support them. And when we start to practice sit to stand without using their arms, they struggle. They either don't have the strength through their legs or they don't have the balance as well. It's such a simple movement that we do over and over, but we have to go back and work on it because we start to lose that if we're not doing that strength work.
Sure, absolutely. Even just the same as like just walking backwards. Think about how hard it is for people to just walk backwards and how much you have to really focus on it to do it. But interestingly, walking backwards is the solution for a great many knee problems that we run into just because of the dominance that people get in their quad versus their hamstrings. And just having them walk backwards changes that firing and it solves a lot of those problems.
It's funny you mentioned that because I have a balance beam in the studio. I say it's a balance beam, but it's literally, about an inch thick that I roll out along the floor and I get my clients to walk forward. And as you said, as soon as they have to start to walk backwards on it, they completely lose it. Even sidestepping on it, and we do balance work on it, with weights and things like that. But that going backwards seems so foreign to so many people because it's just something most people don't do as they start to get older.
Absolutely. Absolutely. You take it for granted. It's just like balance. It's use it or lose it.
And when it comes to maybe some of the misconceptions about spinal health and scoliosis, is there anything that kind of comes to mind that you'd like to kind of debunk? I know when I get a lot of clients in, they'll often ring me and say, oh, I've hurt my back. So the doctors just told me just to lie down and rest and not do anything. So that's one I hear all the time.
Oh, and thankfully, at least here in the States, most people don't do that anymore. They've sort of accepted that that's just terribly outdated information now. Like literally doing nothing after you hurt yourself is about the worst thing you can do. Because in reality, most adults at least, most of the problems that we run into, especially if they persist for longer than 2 to 3 weeks at a time, are really problems that at their core are consequences of deconditioning. And not necessarily like the size of my bicep or things like that, but just the fact that if I'm not, for example, we run a lot of adults that have shoulder problems, okay, from just postural issues and all that. And they don't necessarily have any intrinsic shoulder damage. There's no tissue damage or anything, but they're having a lot of shoulder pain. And the reason why they're having a lot of shoulder pain is because a lot of the deep joint stabilizing muscles in the shoulder aren't being used. And it's those deep joint stabilizing muscles that send a lot of sensory information back up to the brain to tell my brain, where is my shoulder at? What is the status of my shoulder at any moment in time? And if the brain's not getting that information back enough, and I start to move my shoulder around, well, now my brain sort of goes into like protection mode. And the brain says, no, we're not going to move that way because I don't know if you're going to hurt your shoulder or not. And we're going to protect you from doing that. And so a lot of times our perception of pain is actually not true pain. It's more of the brain trying to invoke something to prevent you from moving a certain direction because it thinks it's going to hurt or it thinks it's going to be injurious to your shoulder, even if it's a totally innocuous movement. And so a lot of therapy and rehabilitation strategy has to be about shutting off that natural protective wiring so that the shoulder can just go back to normal and the brain's like, oh, yeah, okay, my shoulder's fine. And then a lot of that pain signaling just shuts off on its own because it's unnecessary.
And I think too, it's people becoming aware of that as well, that that is what happens, and having that knowledge then makes a difference, because then you have the power to go, okay, we're in this state, this is what's happening, but now I know that, then I can work with someone to, build on that movement and move through that pain slowly and gradually as I build up mobility and strength.
Absolutely. 100% agreed. And then to apply that over to scoliosis more specifically, I think one of the biggest misconceptions with with the curvature that everybody calls scoliosis, and this kind of alludes to what we were talking about at the beginning of the podcast, is that scoliosis, what I think of the term of scoliosis, I don't think of just the curve like most people do. Most people equate that curve on an x-ray as being representative of the entire condition. Well, in reality, scoliosis has, like we've mentioned, genetic components, hormone components, bone density components, digestive components, different neurochemistry components. And all of that together collectively is what I call scoliosis. The curvature just happens to be the main musculoskeletal symptom of the problem. It's not necessarily the problem itself. And to kind of take that down to a little bit deeper of a rabbit hole, the curve actually isn't there due to a random event. The curve is there because your brain actually put it there as an adaptive response to a different problem. And that problem is due to poor or asymmetrical growth and lengthening between your spinal column, the actual vertebrae, and your spinal cord that's sitting inside of it. And so when you start to grow, when a child starts to grow, and of course, usually they grow at nighttime or they'll hit their main puberty growth spurt and shoot up like a weed. But if their spine is growing faster than the spinal cord is lengthening, at some point you start to get this vertical tension on the spinal cord. And when that happens, the brain, of course, senses that and says, Houston, we have a problem. And if I don't fix this problem and my spinal cord tears, I'm going to end up in a wheelchair or worse, depending on where that tear occurs. So the brain literally causes this coil down effect in the spine to, as it coils down, we're promoting slack or introducing slack into the spinal cord itself to get rid of that vertical tension. Now, of course, the brain looks at this and says, yes, having a curve in my spine is not ideal, but guess what? I can live a long, active, healthy life with a curve. I can't do that with a torn spinal cord. And so if I have to pick between the two, I'm going to pick the curve. So as part of scoliosis treatment, I can push on that curve all day, whether it be through exercise or bracing or even surgically fuse it straight. But if I don't get rid of that underlying stimulus that the brain was reacting to in terms of that vertical tension, the curve's just going to go back over time. And we even see it in people who've had fusion surgery. Their curves still worsen over time. Now, it might not be as fast as somebody else because now their body is literally fighting titanium, but their curves still worsen over time, and all of the long-term surgery literature shows that. And the reason being is because they never got rid of the reason as to why the body had to make that choice in the first place.
Mm. It's super interesting, isn't it? Like when the body will adapt and it will find what it thinks is a solution, whether or not it's the optimal solution it is for it at the time for survival, because at the end of the day, the body just wants to survive.
Absolutely. And it will always pick whatever decision allows it to survive in the short term, even if that means a consequence in the long term.
Mm. And when it comes to sort of finding a practitioner, is there a scoliosis association, or is there, somewhere that people can go to find, chiropractors like you and that really work specifically with scoliosis?
Sure, sure. Well, I think worldwide, the main governing body of conservative treatment is SOSORT, the Society of Scoliosis, Orthopedic, and Rehabilitation Treatment. But here in the States, I mean, um, we don't necessarily have an academic body like SOSORT in the United States. But within the United States, we have different groups that, like we have PTs that specialize in Schroth therapy or C's therapy, or within the chiropractic profession in particular, there's the Clear Institute, there's ScoliSmart. The company that I work with is called Back Genius, but really it's just about like Back Genius, for example, has a network of doctors throughout the country that their sole motivation really is to work on scoliosis patients and to employ all of the strategies, not necessarily just the physical tools.
Yep. And I've worked with a number of physios that work with the Schroth method. And they went to, I want to say Germany to do their training and then they've brought it back to Australia. When it comes to the sort of different movement methods or methods as such, is one better than the other, or is it really just finding a practitioner that works for you?
I would say I would say the latter. I mean, obviously, you do have to kind of gel with your practitioner for sure. Um, because I think in reality, whether I'm talking about Schroth or because even within Schroth, you have German-based schools of thought on it. You have Spain school, Barcelona schools. Even here in the States, we have different, thoughts on Schroth therapy and how it should be implemented and some of the particular therapies go. So all of them really at the end of the day, whether I'm talking about Schroth or C's or within the chiropractic sphere, we have a technique called chiropractic biophysics, which teaches something called mirror image exercises. They're all really, if you want to boil them all down, they're just three-dimensional autocorrective kinds of postural exercises. I don't necessarily care what label you give them because at the end of the day, they're all really trying to do the same thing. So as long as you can get into a practitioner who excels at being able to implement it and explain it on a per case basis, to me, those are the most valuable people, not necessarily what particular method they're using.
Yeah. And if there is, any listeners kind of listening in and they're either maybe struggling with general back pain or maybe they have scoliosis and they're struggling with pain as well, do you have any specific advice for them?
Yeah, I think so. First and foremost, I rarely, especially if you've had a problem for a long period of time, of course, scoliosis is kind of an epitome of that. You can't just rely on physical treatments to solve the problem. Because by that point, most all chronic issues have a metabolic component, they have a lifestyle component, they have a dietary component. And if you're not hitting on all of those things, you're not going to get the level of improvement that you're hoping for. Now, maybe if I'm just doing an exercise-based therapy, for example, for scoliosis, maybe in the short term I'm helping them pain-wise, maybe I'm helping them stabilize their curve a little bit. But if they don't continue with that exercise program forever, and let's face it, who does? They're not going to necessarily maintain the changes that they achieved because they haven't done the work on the back end to make sure that they got rid of the reasons as to why they developed that problem in the first place. And I don't care what problem you're talking about, you have causative factors, contributing factors, and so on. If you don't address all of them, the permanency of any benefit that you're going to get is going to be very slight. And it becomes difficult to correct a curve for 30 years if you don't get rid of the reasons as to why that curve started in the first place.
Mm. I 100% agree because I'm a nutritionist, studied university degree. I'm a Pilates instructor and I'm also trained as a breathwork facilitator too. So I've kind of got the nutrition, the movement, and then the nervous system kind of coming in. And people often look at me and go, why have you done these multiple trainings? And I said, because, like you said, when I'm working with somebody in the Pilates studio setting, we can get them to a certain point with their movement. But then that might be the next sort of 20%, we can't get them any further. But then when we look at, say, nutrition and lifestyle, then we get a little bit more. And then when we dial in the nervous system, we get a little bit more out of that too. So bringing in all the systems together and looking back at the root cause, rather than, you said, I will have some clients that have been referred to me because they've been seeing, let's say, an osteopath, and it reduces and eliminates some of the pain for a period of time, and it keeps coming back. So until we go to that root cause, then it's always going to be there.
Right. Absolutely. And even just to bring the nutrition component in for a second, just think of like how many people don't even have adequate water intake. I mean, you can boil it down to something that basic, right? And the easiest way I describe it, and I actually have done this before in my practice, is I will go into our break room where our refrigerator is and pull out a piece of, or a pound of ground beef in a package. And then I'll pull out a piece of beef jerky. I say, these are both cow. These are both beef. What's the difference? Water content. How stretchy is the ground beef versus how stretchy is the beef jerky? And then it makes sense as to why, I wonder why I have tight hamstrings.
Yeah.
I can't stretch a piece of beef jerky. You need water intake. So there's always a nutrition component to every chronic musculoskeletal problem.
100% agree. So many of my older clients only drink tea and coffee. They never drink water. And I'm like, well, no wonder your fascia and everything is so tight. You're dehydrated. Like, we need to get some hydration into this system. And like you said, whether or not it is coming from food, maybe if you're not a water drinker, you can get soups and stews. There's ways we can get hydration and collagen and things from our diet. But yeah, it's looking at different ways we can do that. And that's where whole foods is a really big part. And as you said at the start of the podcast, we're moving so much more away from that to the processed food system that we're losing these basics, and it is affecting us, in multi different systems.
For sure. And I mean, there are a lot of directions you can take that, but it even goes down into the public education system where we have kids that, who sit here and make comments like, well, I don't know why we need farms anymore. We have grocery stores. It's just, I don't know how to respond to that.
Yeah,
Uh,
our society has changed so much that we are very removed from our food and how it gets to the grocery store, that I think, they do touch on it in Australia. In schools, they do go through it, but a lot of that needs to come from home too, talking to your kids about where your food comes from and how it's made, and taking them down to, we go to the local farmers market and talking to the farmer and that sort of stuff. That all helps, but we are losing a lot more of that now as we sort of go further with our society.
Unfortunately, I know it's going to be at some point, everybody's just going to take this. It's going to be like Star Trek where everybody takes a pill and that's their lunch. And that's, scary thought, but yeah.
Yeah, I know. We're getting closer and closer to that, unfortunately, though.
Yes, for sure.
Now, looking to the future, where do you see sort of advancements, or what advancements are coming through in that sort of scoliosis realm?
Yeah. Well, first, I think one of the things that I have been really focused on in my practice career is trying to figure out what is the best way in which we can prevent scoliosis from happening. And I do think at the end of the day, once that's figured out, it will be far easier to prevent a curve from happening instead of trying to improve an existing curve. And we're compiling, especially with the assistance of AI now, we are compiling enough data to develop algorithms and predictive models to say, okay, if a child has a certain pattern of genetic predisposition, they're more likely to develop a curve once they hit their main, pre-puberty growth spurt kind of a thing. And if we can then do things, so a lot of those genetic things that we look at are things that can be dealt with from a functional medicine perspective, meaning lifestyle, dietary, nutrient kinds of recommendations to minimize the impact of those genetic predispositions on their downstream physiology. And if we can do that in a real world sense, even if all we did was to reduce the incidence of scoliosis by, say, half, now we've done humankind a big thing.
Yeah, that would be amazing. And like you said, if the numbers are growing, if we can reduce it by half, then, it's only going to be better for everybody, isn't it?
Absolutely, absolutely.
Now,
Spare who knows how many kids from surgery and all the other things that happen.
well, that's it. And everything that comes with it. I mean, even working with a few of the teenagers that I've had being in those back braces, they're uncomfortable. They don't want to wear them. They get super hot and, they're expected to go to school and kind of fit in with everybody else. And there's so much happening when they're going through puberty, hormonally, but also socially, that if kids don't even have to go through that, then that's a bonus as well.
Right. 100% agreed. And that's why I always make the big push when I talk to families where maybe their child has already been given a hard brace, is to say, look, you should never be doing any one single therapy for scoliosis. It should always be a multimodal combination kind of a therapy. Bracing is something that could easily be done as a nighttime only thing if you're combining it with other therapies. The reason why they don't is because, they don't combine it with anything else, so they're only left with doing it for 23 hours a day. Well, what if you gave them options for promoting active stability and, helping their hormone status and their, normalizing their neurochemistry profiles so that you're not impacting all that growth in a negative fashion, and now you're bracing just at nighttime when you actually are growing. Well, now it doesn't help but to increase the rate of compliance on those patients, because most young teenagers that I talk to and manage, they're more than happy to wear it at nighttime as long as they don't have to wear it to school or to, soccer practice or all of these other things, because now it's interfering with their social and daily lives. Their compliance rate goes way down. But if we can just have them sleep in it, compliance goes way up. And it's just as effective, especially when you combine it with other therapies.
Well, I think like one of the teenagers that I taught in particular, I think the only real reason she liked coming to Pilates was because she could take the brace off for an hour while she did class.
That's probably exactly right.
Now, before we wrap up, I always like to ask my guests that if there's one piece of advice that you could give to our listeners that after listening to this podcast, they could go off and instigate straight away, what would it be?
I would say, first and foremost, don't accept the idea that if you have a child who has been newly diagnosed with a curve, don't accept the watch and wait and do nothing kind of approach. Don't accept that. There are things out there that you don't have to travel to that can be done remotely, from a telemedicine model. Half of my patient base I have never seen in my office for one day. I just manage all of the other aspects, and they just get physical treatment done locally if necessary, or we do instruction, via Zoom, just like this, to teach them how to do basic at-home exercises. Don't accept doing nothing, because nothing just sets your child up for doing nothing, sets them up for failure. And the other thing, I think we're at a point in terms of medical technology where don't also assume that your child doesn't have scoliosis just because the pediatrician had them bend forward and they didn't see anything. That Adam's bending test, as they call it, has so many false negatives attached to it that there are a great many children who actually have a 10 or a 15 or a 20-degree curve, even though when they bend forward, their spine looks perfectly straight visibly. So at this point in time, especially with the fact that most all practitioners anymore have very low radiation x-ray machines, it's always worth having your child x-rayed if you have any inkling that something is wrong. I would not rely on that forward bending test by itself.
Yeah, I think that's great advice. I'm in the realm with my Pilates that I work with people, but I'm not a diagnostician. I don't diagnose. So often people will come to me and we will do the Adams test when I'm doing their postural assessment and stuff. But again, one client I picked up that her son doing that Adams test, I said, have you been to see an osteo? He does appear to have a curve, but again, this is not a diagnosis. And she was always like, you were the first one to pick up on it, blah, blah, blah. And I'm like, it almost, coming from that, as you said, it's almost, you can sometimes see, you can't see, depends on the body, depends on the curve, and it shouldn't be the only way. It's, I do it as almost just like a double check, but go to someone that is qualified that can do all the testing that you need and do it comprehensively as well.
Excellent. Excellent.
Now, where can our listeners reach out, connect with you, and find out more about what you do?
Yeah, sure. Well, I have a podcast as well. It's called Scoliosis World, and it's on YouTube, Simplecast, pretty much anywhere you can get your podcasts. My main clinic website is called scoliosispractice.com. And then our main team of practitioners around the United States is called Back Genius. And we work with people from all over the world. I think at last count, we've worked with patients from, I believe, 39 countries. Some of them in the office, some of them remotely, just depends. But those are the most direct ways to get a hold of me.
Amazing. Well, thank you so much for coming on the show. I work with this on a daily basis with my clients, and I think it's so prevalent, but people just don't talk about it enough. There's not enough information out there. So it was fabulous having you on the show today.
I appreciate you very much for having me on, Kate. Thank you.